But again, just gather your questions on a bit of paper and speak to whomever you wish to speak to. I'd just like to, once Stephen's obviously, other side Steve, sort his, that's it, should go on. Dr. Stephen Marks, consultant paediatric nephrologist and also chair of Radar. He'll give you more of a thorough update on obviously the Radar side of it all that Sally's obviously briefed on. Dr. Stephen Marks.
Thank you very much indeed for the kind introduction and the invitation to come and speak to you today about Radar. I'm missing the microphone. I thought I could do the Jeremy Kyle show, but no, it's fine. I think is my voice loud enough in the back? My Scottish dulcet tones get all the way there. So what we're going to do today is to look at a good way of studying rare kidney diseases. And Sally has basically set the scene very nicely for me just to talk about what that is and how we actually move and work forward. The problem with rare diseases is actually what does it mean? And in fact, internationally we don't know what it means because it depends where you live and who you write your statutes. So in Europe we say about 1 in 17 of people are affected by a rare disease. So if you actually look at it collectively, that's not very rare. But of course each of the diseases themselves are actually going to be quite rare. Definitions vary from 1 in 1,000, which is quite a lot to me, to 1 in 200,000 for each individual condition. And out of all of the rare diseases, of which there's about 6,000 medical conditions which could be labelled as being rare, if you look at them, about 70 to 75% will actually affect children. Now what most is meant by rare diseases has actually changed, and the definitions that are beginning to come out are about having a condition which is very rare, whatever that means. And for example, in America, they like to say, well, 200,000 Americans will be affected by a rare disease. So that equates to them being about 1 in 1,500. If you look in Japan, they say 50,000 people, so that would equate to about 1 in 2,500. But what they're trying to say is that these are conditions which our understanding is low, but which have potentially life-threatening or debilitating outcomes, which may of course mean, for example, requiring dialysis or transplant for a kidney disease. And I think what we did in the UK is to try and be at the forefront of saying that we know that there are lots of rare conditions and we need to do something about it. So for example, on the road where my hospital is, we're building a rare diseases building which is going to be used to study lots of different rare diseases which affect children of various ages. So the UK Rare Disease Strategy for Kidney Conditions looked at what is it that we're trying to achieve, and what we're trying to achieve is look at different phenotypes, so different conditions and how they affect people and how they may or may not present. And I think what Sally was trying to give you an indication is that trying to say what a patient has got can actually be quite complex. And for example, if you look at the area of cancer and oncology, for years what happens is that you try and pigeonhole a patient into a box, and once you've done that as well as you can with the information that you have, you can then say, I have a box full of this number of patients which we can have a trial where we can say this is what we believe is the best treatment for this condition today, but I've got another idea, what about trying this condition? And as Sally was trying to say, that's really trying to, where you toss a coin and it lands and you decide whether you're going to have one treatment option or another. And for example, if you look at children who've got a form of leukemia, the commonest one, which is acute lymphoblastic leukemia, and one of my friends had this as a child who's now in his 40s. When he was initially diagnosed, the outcome was about 20 to 30% survival, and now we're talking about the survival is well above 17, and some of the phenotypes it's as high as 90%. So I think it's understanding the processes for how conditions happen and why they happen, and MPGN, like many conditions in medicine, are likely to be that there's a genetic predisposition but something else happens, and whether that's a virus or something which is activated, or in MPGN the complement system seems to be activated, then that will hopefully lead us to understand what potential treatments are going to happen. Now, we've talked a little bit, and people have been asking questions about radar, and the problem is that you need a common infrastructure to make sure that you're getting as many patients as possible with rare diseases onto databases. And what you need to do is not only educate patients and families, but it's also the doctors and the teams looking after these patients so they're aware of what is out there. And I think that radar is a platform by which we can get good, comprehensive identification of patients. And it is a robust system. It's being currently updated, and it is likely in the next few months we're going to go live with Radar 2, which is, again, I've seen the prototype, was emailed to me this week, and I've gone into it, and it is an improvement. There were problems with Radar, partially because when we first sat in a room and we thought about what do we need to do, what do we want, we managed to have enough money to get somebody who was going to set up a database. Usually they're quite young people who work by themselves, and then as time has gone on, obviously we need a little bit more of a robust system, and I think Radar 2 is actually going to hugely improve the amount of data and how easier it's going to be to capture that data in a robust manner. And what we hope is that something like Radar will be able to give ongoing, and as people were asking, I think it needs to be lifelong. So it's about having all the information collected over time about what happens with the disease, when it gets worse, why might it have got worse, what treatments changes were made at that time, for us potentially to understand and to make improvements with time. So we've actually developed two websites. There's the www.renalradar.org and the www.rarerenal.org websites. And they are different, but and I'll talk you a little bit through why they're different. But it's about making sure that we've got the infrastructure, and a lot of the NHS IT systems, I will admit, are probably a few years behind what you might get in the City of London when you go into the financial districts, when they've all got fast computers. My first question when I went to the national meeting of Radar is it going to be slow? And they said, oh, don't worry, it's going to be fine, your speed won't be a problem. Of course, I logged on to my site, and of course I've got an old version of Internet Explorer because that's what my trust has got. I'm not allowed to download any other, because if I download something, it could potentially destroy the whole computer system. So I'm not allowed to have Google Chrome or Firefox, which of course would be much quicker. So yeah, there are issues with NHS IT, which hopefully will get better in years to come. There's a lot of information which we've put up there, and I'll talk a little bit about that. And that's not just for clinicians, it's also for patients and families as well. And the idea being is with time, we will be able to put up a lot more management and diagnostic protocols written by the individual groups, which I'll talk a little bit about. And my view is that it will empower to have the latest research, and will also be important in getting patient forums and chats, potentially in the future, can come off that, which of course would be great for the MPGN and dense deposit disease support group, or a link in to the two systems would be my vision for the future. So when we sat and we were thinking about having the National Registry of Rare Renal Diseases, which was nearly a decade ago, we decided we needed a database which was fronted by a website which is going to be easily accessible. It was to be developed using some of the IT infrastructure which is already available through what we call the UK Renal Registry. In 2015, the UK Renal Registry collects data on every child and every adult who is in a renal unit who has kidney disease requiring dialysis or transplantation. That is a given, and it has to be. So even if your IT systems in your hospital where you go are very poor, if you require chronic dialysis, the definition being that you're on dialysis for more than 3 months, then every year your hospital will be sending returns. What of course we don't have is a system which hopefully UK Renal Registry in a few years will change, we'll be collecting more data on more patients. The first thing is, instead of just doing an annual return, it will become a quarterly return. So every 3 months, because as hospitals and computer systems are improved and everybody's going more automated, it'll be very simple to press a button and export the data every 3 months than it is to manually do it every year at the moment. The next thing will then be, well, what about patients who are nearing dialysis or transplant? So those who have got a low kidney function, and we use the term glomerular filtration rate, and again we will probably choose values. At the moment we say dialysis and transplant is about less than 15. We'll probably initially start looking at 15 to 13% kidney function, and then probably 30 to 60% kidney function. When we first sat and were having discussions about what to do, MPGN seemed to me to be one of the conditions that we studied that we didn't really know what we were doing, and that was the reason that we decided on having MPGN. Because MPGN is rare, and when I use the term rare, it is one of the rarer conditions that we use, we thought that we'd lump them together with a group of children who have nephrotic syndrome, some of whom will have MPGN as well. And we created the steroid-resistant nephrotic syndrome group, because in childhood all of those children will have had a biopsy, and all of the children with MPGN will have had a biopsy. And as Sally said, that's your entry point into it, so that we knew that we'd have 2 cohorts of children that we could follow up and hopefully get more funding to understand why these conditions are happening to children. So to show you the complexity of the amount of data that we get, this is basically the NHS Net firewall. So this basically means that it's exceptionally difficult to get information out of their system. So if I log onto a system and send an email via nhs.net from London to Sally in Newcastle, that is a very safe link. And it is much safer than you sending a Yahoo email even to me in my hospital or a Hotmail account. It's got a special platform, which means that that email will not be interrogated. The problem with NHSNet is we've become very bureaucratic in trying to make sure what data should be given, and in fact in day-to-day life people are sending emails that perhaps they shouldn't be doing, but in fact the safety of other information is getting better. But what we have is a warehouse of all these systems. So for example, in my hospital I've got an in-house laboratory system which sends data, which I can then access patient details, and those systems are now secure within individual hospitals, and now people can actually look at them outside the hospital if they're looking at them in a secure network. But we already have data which is going to the UK Renal Registry. SRR is the Scottish Renal Registry, which is slightly separate but feeds in to the UK Renal Registry. We've got radar groups, and we've got our own system in paediatric nephrology, so looking after children with kidney diseases, our British Association for Paediatric Nephrology, which oversees the data which is going to form part of the UK Renal Registry with regards to the paediatric reports. But of course there's lots of other, if you go and see your GP's probably got a hospital system nowadays, and they've got their own system for drugs, and of course that's different from the hospitals. So there is a lot of data which is held on patients, and if you or your loved ones had a transplant, then there will be data on NHS blood and transplant databases as well. So you can see that there's different warehouses, and what you have outside this is RPV, which is Renal Patient View, and this is a way by, if your hospital is signed up for this, and again, like anything in 2015, it costs money for the hospital to decide they want to do that, and if they do decide they want to do it, you also pay, your hospital will pay a fee per patient. And this is a way of getting your, for example, your laboratory data to find out what your latest creatinine is, either in an adult unit or in a paediatric unit as well, for somebody who's got kidney diseases. So we heard a little bit about the background of how initially we went to get some money from MRC, and then the British Kidney Patient Association, and the fact that we've got IT platforms which are now being able to speak to each other. And when we're looking at rare disease groups within the renal community, we've now got 20 research groups. I talked about the 2 initial pilots that we've had, and over the last 4 years We've had addition, as you can see, of 8 groups in 2012, 3 in 2013, 4, and we've now got an additional 3, so we've got a total number of 20 research groups. And the question is how are they going to survive, how are they going to be sustainable in the future, which I think is an area for discussion today with what you can do in helping the funding for the rare conditions. So this is the first website that I touched upon, which is rarerenal.org. So if you type this in, you come to a home page which gives you information on rare kidney diseases. It gives you information on how to navigate through the site itself, and it is actually pretty easy to do. And you can see now that we've just recruited as the 3,000th UK patient onto the site through Radar, which is excellent news. All the information corresponds to information standards, and we've got people who read through the information to make sure that they're written and are approved for the standards of the average person reading without a medical knowledge. Here are the rare disease groups that you've got, and you can see here we are with the terminology of the membranous proliferative glomerulonephritis, dense deposit disease, and C3 glomerulopathy. We thought it was important to put all of those there so that anybody who was on the website could see that if they had one of those conditions, and they should link onto it. In the past, we previously just put MPGN and dense deposit disease, and then we got feedback where people with C3 glomerulopathy that felt that had been told that they'd had the diagnosis and realising that we were still wanting to keep them, which is why we made the update on the website. So if you look at all of the diseases, there's now 42 potential kidney diseases, so each rare disease group may be looking after patients with more than one condition, and as Sally's second slide showed, you know, there's a whole list that would of course be important to include in the MPGN group. If you look at the broad category, we're now talking, as we said, of 27 groups together in the totality of kidney groups. And one of my favourite ones, which is also from the Hammersmith, where Matthew works, is pregnancy and chronic kidney disease, just because I didn't know pregnancy was a disease. But if so, it's getting pretty rife in London. So, if you go on to the MPGN, dense deposit disease and C3 glomerulopathy, you'll have a little bit of information about what the group does, what our activities are, some of the links to the support groups and information which links on to you. So Sally's talked a little bit about the national study. This is the members of the group from the professional sides, and obviously the patient representatives on it as well. And we have our own website, and we also have an email. So this email then comes directly to me. So if anybody clicks on this, then that gets sent to me and I will respond. And I would probably say now on average, probably about 10 emails internationally a month from people, my child's affected, or even adults saying, what's the latest, and you know, what should my treatment be? And of course, as Sally said, it's actually very difficult to answer questions, because for most of them we don't know until we get more set up. So there's a lot of patient information which you can see. So if you go up on the left hand side, that takes you to the patient information link, and there's various things that we look about. One is how does the illness affect people, and it talks through some of what Sally was saying about developing blood and protein in the urine, nephrotic syndrome with swollen face and legs, and what can be done about it. And we talk a little bit about the kidney biopsy, about some of the drugs which people may be on. So ACE inhibitors, so they're the drugs ending in PRIL, or angiotensin receptor blockers. Those are ones which end in ARTAN. We also link into your website and the patient support group, and we have a little bit about, you know, what we're talking about with opportunities for research and development and moving things forward in the future. So I think that the capability of Radar to potentially cover all UK adult and paediatric population is there. Your questions are very interesting with respect to what do I do if you don't have a setup in the hospital that either I go to or my child goes to. We have now enrolled all of the UK paediatric nephrology units, and the battle is really to get all adult hospitals on board as well. The issue, like anything, is that many people involved in wanting to set it up are busy clinicians. They may not have support from their hospital, so they're all employed by the NHS. This is deemed as being part of audit, research and development, which they may not have in their job plan, and they may not have support staff. I know when I started out it was very difficult to try and get things, but what you can say to your doctors is that if you get set up on Radar, then it's an actual additional amount of money can come into the hospital, and there is a support network whereby nurses and data managers can assist in getting the data together. What is very interesting is when patients get enrolled in Radar and in projects, that it does take a while before that money actually comes to the institution, and very often it won't come to the person who's doing it. And I think that's been the problem in some of the units, getting people just to do the legwork. I actually say in 2015 that although getting onto Radar is pretty easy and simple, that actually the barriers that we've become so bureaucratic in the UK of doing proper research is such that it becomes unethical, because we have to do so many forms and you've got to get so many people to sign it. It's actually a work in progress for every single research project that we want to do. So again, like most things, it's garbage in, garbage out. How much information do we put into these websites? And I think one of the problems that we've got, that you know, your question was about having the data, is you can only use the data as to how much is put in. And what I would like to see more is actually patients being able to put some of their information, or seeing where it is that maybe having an idea of what information that they put in, and then asking the doctors, you know, which is right and which is wrong, and how much more information can I put in about what drugs I've been on. I think that we need to look about the sustainability of these, because a lot of it is about money, and we need to get funding that we managed to get, as you've heard, but again that's going to run out, and where are we going to get the next tranche? And we discussed at our last meeting that a few of your members, Andy as well was present, of maybe linking in the fact of getting research money from your charity. If you've got donations, then that can actually be managed by one of our networks of who are under the Academy of Royal Colleges, where we can actually put in research grants, but your money will specifically be used for doing research in MPGN, dense deposit disease and C3 glomerulopathy, and that would be open for anybody in the United Kingdom to put an application in for. So this is the renalradar.org, where the actual data goes, and as I said, I haven't put the screenshot of the system which is in development, but it's very, very similar kind of outlook, and it means that if I log in, that I can see a list of patients within the sites. You can actually fill in the data for each individual patient, and each patient is given a radar number, which you can see in the top right that you can put in. This is obviously in the test website that we've done. And what we've seen is there's been a huge increase over the last 7 years. We've now got 42 adults and paediatric units on board, with an aim of 2,395, and as Sally said, we're hoping to get at least 300 patients with MPGN. So I just wanted to talk a little bit about kind of Radar and what we're doing within MPGN. So Radar basically gives you the infrastructure for making sure that you capture all the clinical data, which is disease specific. For example, if you had everybody in the country and then you notice that some diseases happened in one place, then that might be important to work out why that might be. But what we're doing with MPGN, and really it's only the MPGN and the steroid resistant nephrotic syndrome groups have done, is basically having what we call type 2 data, which is where basically we're collecting data and analysis. And I won't talk too much about this because this has been touched on by Sally. But what we're doing with the Radar is collecting information under the remit of Radar, which has got UK-wide ethical approval, And the bit that you need to tell people if your hospital isn't on radar is that you don't actually need a lot of approval for it, because all you're doing is agreeing for your data to be put into a system. When you join with MPGN, dense deposit disease or C2 glomerulopathy, you will have to sign at least 2 consent forms, and you just heard there's been an updated version. And the idea is because one is consenting for this, which is just radar, which won't mention anything about MPGN, because it's about all of the rare diseases and the clinical data being on that website. And then the other consent form is to look at your biopsy and to get specimens, because we're trying to get more data and research to understand what's happening in the individual condition. So the website is not just for data collection, it's got a host of information. It will contain all the up-to-date literature and research reviews and clinical guidelines for doctors who may have few patients with the condition, but also will have additional information for patients and families about the diseases, the tests, medications and research. So we started with one group, and the steroid-resistant nephrotic syndrome group has also been successful.